So now coming to the adrenals. The adrenals are very interesting. There is a adrenal gland which is located above the kidneys. That's why it is also called suprarenal gland. It is present on both sides. Two adrenals are there which is present on both sides. So whenever adrenal is cut into a section and studied, it has two regions. The outer region is called as the cortex and the inner region is called as the medulla. So there is one region which is cortex and medulla. So first we will discuss the medulla because it does not have any divisions. So medulla, what does it do? It is like a mini sympathetic system there. So it is the sympathetic system is present. Like they will have extensive amount of neurotransmitters of the sympathetic system. So whenever they are stimulated, epinephrine is released a lot. Epinephrine will be released more than norepinephrine. Whereas in case of neurons, when you talk about neurons, that is sympathetic neurons, there norepinephrine is released more. Here the storage from epinephrine is released more. So they will give you a clue. A patient has having high levels of epinephrine, then most likely it is a peripheral epinephrine release. That is from the adrenal medulla. And tumor of adrenal medulla is one devastating condition which is called as pheochromocytoma. Pheochromocytoma. This is a tumor of adrenal medulla, not the cortex, it is the medulla. So what will happen? All the sympathetic activity will be increased, heart rate is increased, contractility is increased, and one more devastating thing is there is decreased mental judgment. The person will be very aggressive and they can go up to the levels of harming other people. If you people are watching the famous series of House MD, there is a separate episode for this pheochromocytoma wherein the person would have killed his wife and he will be in a jail. Finally, House comes to the rescue and finally finds out that it is due to this medical condition, pheochromocytoma, and the patient will be, and the patient as well as the person who killed his wife will be, his punishment will be a little reduced considering his conditions. So this can go towards extremes because their sympathetic activity is very, very high. It is a very dangerous disorder. So the only treatment is to remove the tumor. Now coming to the cortex, wherein the major of the hormones are produced. The cortex has three regions and usually they refer with the mnemonic GFR. So the outermost region is the glomerulosa, zona glomerulosa. Second one is zona fasciculata. Then the third one is zona reticularis. Zona reticularis. So these are the three regions. And we should know what are all the substances they are produced there. For glomerulosa, the substance produced is mineralocorticoids. It is mineralocorticoids. Then the fasciculata is producing glucocorticoids. And the reticular is producing the sex steroids. So these are the hormones produced by the representative units. How will you remember it? There is an adult mnemonic for this. The deeper you go, the sweeter it is. The superficial layer is producing mineralocorticoid, that is a salt. Then when you go down, it is producing the glucocorticoid, which is glucose, which is sweet. Then when you go deep inside, it is the sex steroids. So this is the hormones which is produced. But fasciculata and reticularis, they can produce both. They can produce glucocorticoids also and sex steroids also. So first we'll talk about the reticularis part, which is very small to discuss. So the sex steroids are produced. What is the sex steroids produced here? Here they produce testosterone as well as DHEAS. They produce testosterone and DHEAS. What is this DHEAS? It is dihydroepiandrostenedione. So no need to remember the full form, but remember its function. Its main function is to grow the hair. Grow the hair. And even in case of females, the pubic and the axillary hair are due to this DHEAS, both in males and females. Males, hair growth anywhere is due to this DHEAS, but in females also, the pubic and the axillary hair growth is because of this hormone only. Don't think that females doesn't have testosterone. They have minimal amount of testosterone. In a similar manner, even estrogen is present in males, but in a very little amount. So this is about the sex steroid or the zona reticularis part. Now we are going to discuss in detail about the zona glomerulosa and zona fasciculata part. So coming to the zona glomerulosa, we told that it is going to produce a mineralocorticoid, and which is the predominant mineralocorticoid. Mineralocorticoid means salt reabsorbing substances. It is producing aldosterone. And all of us know it, since it is a mineralocorticoid, our ultimate aim is sodium reabsorption from the kidney. So this aldosterone has to do something to reabsorb all the sodium. So what does it do? It activates a specific channel ENaC channel. We will discuss about this channel very detailedly in kidney, but right now you just remember it is epithelial sodium channels. It is present in the epithelium of the collecting ducts. That's why it's called epithelium sodium channels, and it increases the activity of ROMK. This is a specific type of potassium channel. K is for potassium. And finally, it increases the sodium potassium ATPase. Don't worry, this we will again discuss in the renal system also. So it activates 3 of these channels. So this epithelial sodium channel, whenever it is activated, what it is going to do? It is going to take in more and more, reabsorb more and more sodium. And the energy for this can be derived from the sodium potassium ATPase. And for the sodium reabsorption, what happens in this segment is the sodium is getting reabsorbed, and for that potassium is being thrown out into the system. Initially potassium will be thrown out, then on a later stage what will happen is there is an eye cell which is located next to the collecting tube. This is a principal cell in the kidney, this is an intercalated cell in the kidney called the eye cell. First, for sodium reabsorption, potassium will be thrown out, but on a later time. The time period is more and more sodium reabsorption is happening. What it will do? It will throw the H plus out also. There will be potassium loss as well as the H plus ions loss. So this brings us to a syndrome which we will discuss in renal also. That is Liddle syndrome. What happens in Liddle syndrome? Liddle syndrome is a gain of function of ENaC. Here what is happening is there is increased activity of ENaC channels. Whenever ENaC activity is increased, what I told you, it will cause sodium reabsorption. So the first problem is sodium reabsorption. When more and more sodium is reabsorbed, who comes along with it? Water comes along with it. So what will happen to the ECF? There is an increase in ECF. And what will further happen? There will be hypertension. So hypertension will happen. It doesn't stop there. It starts with to cause another problem also. So whenever sodium is reabsorbed, I told you it has to throw some potassium initially. So what will happen? Potassium is decreased because it is going into the urine. This is the lumen side. So it is going into the urine. So it will cause hypokalemia. Then I told you when more and more reabsorption happens, even the hydrogen is thrown out. So what will it will cause? It will cause metabolic alkalosis. So all these features will be there in case of a Liddle syndrome. So all these features will be there whenever there is an hyperaldosteronism also, because aldosterone is doing the same function. So in a similar manner, it is easy to remember another disease which is hyperaldosteronism, which is called as Conn syndrome. Conn syndrome. They will give a classical history of hypertension, and all the features of this Liddle syndrome will be there. But they will specifically mention, if they are asking for a Liddle, they will ask you what is the gain of function. Otherwise, they will say it is an hyperaldosteronism condition. What is the syndrome? So it will be a Conn syndrome. But the features are very similar because the ENaC channels are hyperactive in both of them. So this is all about the Zona glomerulosa part. Here mineralocorticoid is produced, and these are the clinical aspects, Liddle syndrome and Conn syndrome. Now coming to Zona fasciculata. So Zona fasciculata, we saw it is produced, it is the second layer, so it is going to produce glucose, that is a glucocorticoid, corticosteroids. So it is producing the cortisol, that is the most important glucocorticoid, that is the cortisol. What is its action on metabolism? Its action on protein is catabolic, like that of a thyroid. Then fat also it is catabolic. But on carbohydrate, it does both. It is catabolic in the skeletal muscle. So it is directly breaking the skeletal muscles. So whenever you see this persons, their muscles will be weak because it is causing a catabolism, and produces alanine. And it produces alanine. But again, what this alanine is going to do? In the liver, this alanine will go and they will form glucose. So it's like a diabetic condition. So there is some neoglucogenesis also. More and more glucose is there present in the body. That's why it is called as glucocorticoid. It is also called as a stress hormone. Whenever a person is in stress, more and more glucose neogenesis will be formed. What are its other actions? The other actions are anti-inflammatory, anti-allergic, antipyretic. These three features we will see in most of the diseases. And this corticosteroids is like a golden drug for non-medical practitioners. People who are not studying medicine, what they will do is they will prescribe corticosteroids for everything. Why? Because a patient comes to you in fever, it is doing an antipyretic effect. If patient comes to you with an injury, it is doing anti-inflammatory effect. If a patient is allergic to something, it is having anti-allergic effect. So everything, it is like a magic drug. It is curing everything. But the catch here is it has some severe demerits also. Corticosteroids, it is always said that it is like a double-edged sword. it can go haywire also. That's why we should not do over abuse of the corticosteroids. So what does it do? It decreases the lymphocytes. Lymphocytes like an immune cell. It is decreasing that. It decreases the eosinophils also. So our entire immunity of the person is going to go down. Usually people, they will be taking long-term corticosteroids and they will be having with the severe immune depression, immunosuppression, and they land up in severe disorders. And it causes osteoporosis. Basically, it is weakening the bones, which is very dangerous. And when you see patients, they have some history of corticosteroid usage for years together. They would have been prescribed for some minor problem, but they will be constantly taking it because of the good effects of it. But ultimately, it will cause severe deleterious effect. And it causes decrease in vascularity also. There will be a classical history of a corticosteroid abuse, and the patient will be coming with neck of femur fracture because the vascularity to the femur is already less, and if the vascularity is further reduced, it will go in for a fracture, and the person will be a little obese and pendulous also due to the excess neoglucogenesis. So this history also matches with the glucocorticoid abuse. So previously this glucocorticoid excess was due to various reasons, but right now it is due to exogenous glucocorticoids. Because of severe abuse, the exogenous glucocorticoid is one of the most common reason for these kinds of syndromes. So whenever the glucocorticoid is more, there is a syndrome called as Cushing syndrome. This syndrome is called as Cushing syndrome. So all the features of glucocorticoid will be in excess. There will be severe poor muscle development because it is breaking the muscle, poor wound healing because it is suppressing the immune system, and there is stretching of the skin of the abdomen and everything because of the deposition of fats, because fat catabolism is happening. So fat deposition will happen in many places. Fat pads in the face, then moon faces, red cheeks, bruisability, striae because of the pendulous abdomen which is stretching it, it will cause striae. All this will be the classical features of Cushing syndrome. So it has been asked in the image-based questions also. Cushing syndrome, you should remember all this. So all the glucocorticoid or the cortisol functions are functioning excessively here. Then is there any disease where all the cortex hormones, all of them are reduced? There is one disease which is called as primary adrenal insufficiency. Insufficiency means here it is the reduction. Now that disease is called as Addison's disease. This is also very important. And Addison's disease, now tell me what will happen. There is the cortex is completely affected. So both glucocorticoids will be down, mineralocorticoids will be down, and even the sex steroids can be down. So this glucocorticoid is down. So all the effects of good effects of glucocorticoids, they will also be down. Then coming to the decrease in mineralocorticoid, what will happen? The decrease in mineralocorticoid is there is decreased sodium reabsorption. So what will happen? There is decreased water reabsorption. So the person will go for hypotension, and there will be a severe volume loss leading to hypovolemic shock. If the person is going for a shock, then it is called as Addisonian crisis because the person is now not in a disease, he is in a crisis. So this is called as Addisonian crisis. So Addison's disease we should remember, Addisonian crisis we should remember. But I will give you one thing to remember about Addison's disease which will be definitely present in the question, that is the hyperpigmentation. Why Addison's person should have hyperpigmentation? It is completely irrelevant. Here only the adrenal is affected, but he is having hyperpigmentation. It is because whenever there is cortisol, what it will do is it will go and give a negative feedback to ACTH. But what is the problem with Addison's? The problem with Addison's is there is non-availability of decreased cortisol. So there is nobody to inhibit this ACTH. So the ACTH will think the person is not having cortisol. So let's go and produce more and more cortisol. It will try to produce increased cortisol. So the ACTH levels will go higher and higher. But the problem is in the adrenaline. Whatever high may be the ACTH, still the adrenal is not functional. So this increased ACTH, whenever it goes beyond a certain level, it can act on the melanocyte receptors. It is stimulating the melanocyte receptors. So once it stimulates the melanocyte receptor, what is going to happen? The person will have hyperpigmentation. So this hyperpigmentation will happen in Addison's disease. And most of the times, whenever they give a case for Addison's disease, definitely this hyperpigmentation feature will be there. So it is a must to remember.